Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Welcome to episode 3 of the Eye of the Needle podcast. I'm your host, Pam Arlotto. In our first 2 episodes, we talked about the broader change that the industry is going through, and we talked about the overall difficulty of incentives for physicians and other stakeholders in the industry in episode 2. Today, I want to spend some time on the startups and the entrepreneurs that are trying to make a difference in this industry. We see so many ambitious companies with lots of potential that ultimately don't make it. In fact, between 2011 and 2019, investors put $40 billion into digital health startups. In 2021 alone, there were 729 deals at about $29 billion of investment. In the first half of 2024, we've seen about $6 billion invested in 266 deals. But over a 5-year period, at least 60% of those companies fail. And over the longer term, 98% don't make it. So what is it? What does it take to be successful? In this episode, my guest has had a successful startup since 2013. And he's going to share with you exactly some of his secret sauce to being a successful entrepreneur in healthcare. Well, welcome. I have a very special guest today, Dr. Josh Liu, who is founder and CEO of SeamlessMD. He's got a very interesting perspective on selling into this industry, building a company, and scaling a company in this very interesting industry of ours called healthcare. Change is difficult, as we've always said, and I think he's got a few tips to help those of you who are trying to innovate, transform, and ultimately drive improvement in this industry. So welcome. Can you tell us a little bit about your journey to becoming CEO and founder of SeamlessMD?
Absolutely. And Pam, thank you for the opportunity to share our story and my learnings. It's an absolute honor to be here. So for folks who don't know me, my quick story is I actually started off in the clinical world. So I did my training in medicine, and some people go into med school knowing what they want to pursue, be that family medicine, surgery, or something else. I actually was a little bit lost, but I got lucky because I had a fantastic mentor who took me under his wing and actually got me more interested in broader challenges in the healthcare system. So I ended up actually doing some research on preventing readmissions back to hospital. And that work got me really hooked on improving quality, safety, and the patient experience. And then around the end of med school, I got kind of bit by the tech bug. Technology startups were starting to become a thing, in the media. And so actually in my last year of med school, I, on a whim, applied to a startup incubator. I met a couple of brilliant engineers, and I said, hey, there's this readmissions problem I've been working on. And we decided to actually go and build technology to better support patients outside the 4 walls of the hospital to see if we could actually do something like prevent a readmission. And so we actually launched our company SeamlessMD through that incubator. I graduated, never actually started my residency because we went full time on the company, and I've been doing this for 12 years now. And just to give you the quick story on what exactly we do. So the analogy I like to use is travel. So imagine you're driving from point A to point B. We used to use maps, right? Paper
Right.
maps, but now we're on GPS, and we know it's faster, it's safer, it's better. And what was crazy to me was that the healthcare journey for a patient, and that could be, going through a surgery, a cancer journey, or something else, those journeys are far more complicated than travel, but there was
Right.
still no GPS for patients. We would give patients paper and verbal instructions, and patients would say they forgot them, they would lose instructions, they're hard to follow. And then the care team would tell us that they would feel as if they're sending a patient into a black hole, especially after discharge from a hospital.
For sure.
And yeah, and there's no easy way to keep patients on track. There's no easy way to keep an eye on them. And if we can't do that well, patients can end up with worse outcomes. They can have longer hospital stays, avoidable visits back to the hospital, higher costs to the system. And so we basically started Seamless MD to provide a GPS to guide patients through those journeys.
Well, we always talk about getting every patient to the right place at the right time, but how do we do that if they're confused? I mean, I think that's brilliant. And you saw the problem and looked at some of the new solutions and have applied those. And one of the things that we see quite a bit as consultants is we'll get a call from a large company, or we'll get a call from a startup, say, or from their investor, and saying we think they've got an aspirational idea, something that's brilliant, but they're having difficulty executing. And I did a little homework and found out that over 98% of digital health companies ultimately fail. And I'm just curious, in that time that you've launched your companies, and you've obviously, just looking at your website, gotten a number of nice logos and brands and clients, what in that whole time period are you most proud about in terms of being persistent and sticking with it, and actually getting that traction that's needed?
Yeah, so I'd say a couple of things come to mind, because you're right, Pam, it's really hard. Well, I'll say this. I think what I've realized is that it's not that hard to, build technology, especially software nowadays. It's in 2024, it's so much easier to build software than even when we started 12 years ago.
Right.
But the really hard part is, how do you build technology that patients actually use, that actually drives a better outcome at a lower cost, and that actually gets adoption by the healthcare system. That's so the technology is like not easy, but it's not the hardest thing. It's all the other things. And so what I'm really proud of is, I would say, number one, we've gotten real adoption in the healthcare system. So right now we work with approximately 50 hospitals and health systems across the U.S. and Canada. The second thing I'm proud of is that we've done a lot of really good work actually being interoperable with the electronic health record companies. So, to my knowledge, we've been the first company in our specific space to have turnkey integration partnerships with Epic, Cerner, and Meditech. So really being a part of the IT kind of framework for health systems. And then lastly, I would say I'm really proud of our solution actually working. And so what I mean is our partners have on their own done over 40 studies and evaluations showing how they've used Seamless to reduce length of stay, readmissions, cost of care, and even mortality. We've had
Mm.
data and patients saying, "Hey, this has actually helped save my life because it's caught a blood clot sooner, it's caught an infection sooner." And so, it's taken 12 years, right? It's a people always talk about like overnight success stories. Well, truly, especially in healthcare, that's not possible. It's more like a 10-year overnight story in
Yes.
our experience. But super rewarding, absolutely.
Well, you mentioned, I think, the 800-pound gorilla, the Epics or the Cerners whoever the EHR, the organization has. And 9.5 times I talked to a troubled organization or a vendor company or solution company, and they go, "Well, that Epic, or that big company is just in my way." Tell me a little bit about the mindset it takes to be successful with those large companies. And because you are not going to, as a small company, will not convince an organization to use you instead of them. So how do you work in concert with them? How do you get into a place that says, "No, I'm on Epic, they can do everything"? I mean, how does that work?
Yeah, I think one of the things that startups have to realize is that it is incredibly, incredibly rational for health systems to think that way. So, if you put yourselves in their shoes, they've built, lots of trust with the Epics, the Cerners, the Meditechs, or just other, incumbent companies who they've spent maybe 5, 10 plus years working with. Those are
And a lot of
large
money.
a lot of money invested, and they have, they've earned, let's say, in many ways, a trusted brand over the years. And so it's very rational that they're going to want to work with someone that they trust. You're right that they spend a lot of money on those systems. So, if they can actually just consolidate onto, fewer vendors that they trust, that's always better for them. And so I think one of the mistakes that smaller companies make is that they think if my product is 2 times better or 3 times better than the incumbent, then the health system should pick me. But the reality is, if you want to overcome the friction of an established, trusted incumbent vendor, you have to actually be 10 times better on some dimension that the health system actually cares about. Otherwise, it's just not enough to remove the friction of the existing incumbents, attachment to the health system. And so like you have to find your own way to do that. There's no one way. So for Seamless, the way we thought about it was, okay, um, maybe we can't be 10 times better on one thing, but we can do several things, maybe 3 or 4 times better. And so in totality, we're 10 times better. So for us, it's always been on our product. We have way more clinical evidence than the
Mhm.
incumbents. So we earn the trust of clinicians that this will actually work. We have a lot more clinical content built on top of our platform, and the incumbents tend to want to be purely tech companies. They don't want to actually figure out the clinical content side. So we put a lot of effort into that. And then just the services we offer, a lot of the incumbents just want to, provide tech and no other services help on top of that. We layer on the services because we focus on actually driving real results and not just providing the tech, which a lot of
Mhm.
incumbents don't want to go that extra mile to actually, do what's needed to deliver results with the tech. And that's our version of being 10x better, but each startup has to figure out in their own way what will make them 10x better. But the key is to realize you can't be 2 or 3 times better. Really, you really have to be 10 times better at the one thing you're going to do.
Well, another insight I read in one of your writings that I think a lot of people don't realize is you said somewhere that you had knocked on the Epic door over and over and over and over again. And finally, you had this big aha of they weren't going to pay attention to you until, why don't you finish the rest of that story?
Yeah. So, I think a lot of startups that want to integrate with, the Epics, the Stoners of the world, they start the way we did, which was we tried calling and emailing, let's say Epic, as you mentioned, saying, hey, we can add so much value to health systems. Why don't you integrate with us? And they would never pick up the phone. They would never answer by email. And then eventually we started talking to our customers. And, with, let's say, Epic, we had a relatively large 15 hospital system on Epic that was using SeamlessMD, was very successful. And we said, hey, wouldn't it be great if we also integrated with Epic to, streamline some of the workflows? And so they went to Epic and said, hey, we want you to integrate with Seamless. And then all of a sudden, our emails were going through and the integration would happen. And that exact same story happened again with Cerner to get our integration.
Yes.
The customer demanded it. And eventually the same with Meditech. And then now it's obvious, but the point is, when I think about it, well, of course, Epic won't pick up my number. So many startups are calling Epic every day asking for an integration. But if a large paying customer of theirs is calling them, of course they're going to pick up, they're going to listen. And to be fair to, let's say, Epic, that rationalizes the investment in the integration, knowing that it's actually confirmed to be valuable by one of their customers. And so now I
And
actually respect it. Yeah.
and you got into that customer by being 10 times better and really, really peeling the onion on the problem that they were trying to solve. I think sometimes we take a surface level problem and say we're going to build something around solving it, but you have to go so many layers deep and really, like in your case, the content and the workflows and really putting the services around it. I had an investor recently tell me about remote patient monitoring, that you can't just set up a tool, you can't just provide monitoring software and tech. You've really got to provide a soup to nuts solution, because nobody in a clinical environment has time to figure out all those pieces to make the tech successful. And sounds like you've done some of that. You've got more of a holistic approach, not just tech first or tech only, maybe is a better way to say it. Is that fair?
Yeah, and you're absolutely right. I mean, you could imagine if you take let's take remote patient monitoring technology as an example. If you take that tech to a clinical team and just hand it to them, the conversations they end up having in the back room is, okay, well, which person on our team should be doing the monitoring? Um, how should I explain this to a patient? How many possible alerts that I could turn on is too many alerts? Do I need to how many times a day should I be checking this? What happens for after hours alerts that go off? So there's all these detailed questions about making this work in the workflow that if you just hand this to a clinical team with no playbook, no support, you can imagine most of them are going to say, okay, well, I'm just going to give up because I don't have time to figure out and do trial and error and figure out the right workflow. But if you bring a team with a playbook that can actually teach best practices, troubleshoot, etc., the likelihood of success is 10 times higher. But if you just hand the tech and say good luck with it, you're setting them up to fail. So you're
Right.
right. It has to be a full package offering.
Right. And I think, what I see quite frequently, a big company will try to take something they've done in another industry and just kind of rubber stamp it onto healthcare, or a startup who they've been to startup school, so to speak. They know about a minimal viable product. They know about agile. They know all the good terms and methodologies, and then they fall flat on their face in this industry. And I kind of think there's some rules of the road that are unique to healthcare that are a little bit different than what it took those entrepreneurs and big companies to be successful in other industries. I mean, what's your experience on that?
Yeah, I mean, so a couple come to mind. I think one kind of is a good continuation of something that we've talked about. So, you know, I used to get it's called a rule that you should, as a tech company, you should try to be as hands off as possible with your customers. Customers should just buy the tech and do everything on their own. And so, as you know, like SaaS or software as a service is like it was a very hot word the last 10 years. And to me in healthcare, SaaS means software and a service, not software as a service, meaning that if you just give the tech to the clinical teams, it's going to collect, dust on the shelf. And so, we have to actually be hands-on, go above and beyond. Sometimes we have to go on site and observe the workflow and figure out, why something isn't working. Or, we talked a bit about how, we actually have to, provide the clinical content and the workflows out of the box and help the customers, configure and basically start with the draft and not start from
Mm-hmm.
scratch.
Mm-hmm.
And those are all a lot of things that if you were a pure tech vendor, you may not do. But if you're willing to do the tech and the services, that's a big thing. And that's not something folks were telling me before. And we had a fight. We had to say, hey, you know what? Actually, no, I think we should invest in the services and the people side, because if we don't, the thing just falls flat.
Well, and healthcare is a very people-oriented industry, and maybe not as digitally aware as some others may be. So I think that's part of it. The people part of it's still very, very important. Any other rules that you've kind of experienced over your time?
Yeah, I would say one is people would always say, hey, as the CEO, you should, delegate more. Don't be so involved with customers. You can't scale. You just basically delegate everything and focus on the business and less on spending, time face to face with customers. And I actually found that, I think, at least in our space, and this may be different for other companies, but for our type of company that's, in a very verticalized, complex space, it's actually really important that I'm client facing more than some other industries. And maybe if we were selling a sales CRM to small businesses who are just trying to, go from spreadsheets to, a CRM application, I wouldn't need to be that involved. But, when you're selling a very disruptive product into large health systems where you're meeting CMIOs and other physician, leaders and executives with complex workflows, you can't just hand that off to someone who recently graduated and say, hey, can you go and navigate that conversation? It's pretty complicated. And so I've realized that I often need to be pulled in for stuff regardless, which is fine. It's just realizing that that's the space that we work in. And the other piece too is that healthcare is very much built on trust, right?
Yes.
You have to earn it. And if you're building a highly disruptive product, we have to spend even more time with the health system to earn that trust and earn the right to be in that workflow. And what I found is that, especially early on, when health systems saw that the CEO or the other leaders on the team would spend more time with customers, dig into the workflows and so forth, it built that trust. If I had just handed that off early to someone who just graduated with no experience in healthcare, we would have fallen flat. We wouldn't have earned that trust. We probably would have, made a lot more mistakes. And so I think folks have to realize if you're entering a very complex space like this, you actually have to spend more time with your customers, not less.
And I assume that's all the way through from developing the sales plan to serving the customer to even how you market and get the word out. I assume you're involved in every step of the way, not just the big vision and doing deals and those kind of things.
I mean, luckily less than I used to be. So you're right. At the very beginning, I was probably involved with almost everything.
Right.
Now I'm a little bit less in the day to day of every client, but like I still will meet clients. I will still go on site and visit customers. I'll still get into the trenches every now and then with the product. So I luckily have a great team now where I'm not
That's
in everything.
fantastic. Yeah.
But I still think that, let's say 10 years from now I'm still doing this, I still will be meeting clients. I still will be in the trenches. I might do things a little bit differently. But being involved and in the weeds, I don't think that will ever change.
That makes so much sense. And I actually think that's part of the secret sauce for success. It's kind of being that orchestra leader, if you will. So tell me a little bit about within, obviously I'm hearing you talk, most of your primary customers are health systems, and health systems have gotten harder and harder to sell into these days. I mean, 40% are still kind of dealing with negative margins. How do you decide? I mean, do you have one primary customer? Do you kind of have to qualify and learn about the health system and who has what responsibility and role before you figure, or do you sell to the whole leadership team? I mean, who is your primary targeted customer when you get a new opportunity and a new health system as your client?
So I would say what's interesting is that we've gone through an evolution over the last decade of who the right stakeholders were for us. So I can tell you, let's say when we first started almost a decade ago, the CMIO, the CIO, the leadership team was never the point of entry for us. They weren't even thinking about using technology to engage patients in this way. And so it was always for us back then going bottom up, finding, clinical leaders such as like the head of orthopedics or the chief of cardiac as kind of the champion to bring us in. And then I would say since 2020, it started to shift where um, sometimes it was the director of a service line, or sometimes it was the CMIO or the CIO or the chief nursing officer. And so now it's actually in a state of flux where really depending on the health system, sometimes we're going top down, sometimes it's bottom up, sometimes it's sideways in. I think long term, it's almost always going to be someone like the CMIO, someone who's involved highly in clinical and technology that brings us in the long term. But right now, it's a little bit of everything as the market goes through this transition where it went previously clinicians only to now more folks seeing value in us, which I think long term is a good thing because now we're getting more of a system wide perspective as opposed to just one department at a time. But it also means that we had to keep evolving our playbook too. So I think one things that I've learned is that we almost have to reinvent ourselves every couple of years, reinvent the product, reinvent our go to market, reinvent how we serve our partners. And so, we have to keep innovating, not just the product, but everything else about the company too.
Well, and I've done a lot of education. I started a crash course for CMIOs 15 years ago with AMDUS, and the role of the CMIO, that's a great example, has changed dramatically during that period. Initially, They worked for the CIO, they were the doc in IT, and they worried about implementing EHRs. And now they have such broader, more strategic perspective, and they're really driving a lot of the change and value within health systems today. Another thing I've always said, now I would like your take on this, is I always tell people, you've seen one health system, you've seen one health system. And while certainly there are patterns in terms of how they think and how they solve problems, but it sounds like you guys do really try to understand who the players are in the health system, what the roles mean, because you could have the same title in 3 health systems and it could mean something completely different in all 3. So it sounds like you guys put some time in up front to really understand who the players are, how they make decisions, and ultimately how they can influence the decision about working with your company. Does that make sense? Does that resonate?
It does. And I think to your point, Pam, every health system at a high level looks very similar, but you're right that the personalities and the motivations and the social dynamics are all very, very different. Because you're right. I mean, you can, at some health systems, there are some CMIOs who, if they spend one meeting with us, we resonate. They go, "Oh my gosh, this is exactly where I think we need to take our digital transformation strategy," and they're very bought in. And then at a similarly looking health system on the outside, you go in and we meet a CMIO, and they might say, "Oh, actually, this is not at all up my personality. I'm more interested in optimizing the EHR, and that's my sole focus for the next few years." And you're right, the title's the same, but the current state, the motivations, the interests are going to be different. And so what's important for us is to meet with lots of folks in the organization and try to figure out, okay, like, are there enough, motivated people? Are there enough priorities that we align with where we can actually do something here? And the answer may be no, and that's okay. There's no point trying to sell something that doesn't solve a real problem right now. But you're right. You actually have to go in and map things out and understand and meet enough people. And I think one of the things that I've become a big believer in is that you can't. The most that we can do is educate people and help them buy, and not just sell.
Oh, that's
Um,
great. That's a great point.
yeah, because I mean, we've had mistakes too where we were great at selling, and it turns out there wasn't really a problem to be solved, and we'd implement it, and then there was no value created, and then the relationship will be over at some point. And so now we're very big on, okay, like, can we actually help you? And we even tell some partners, I don't think we can help you. You really shouldn't buy our product, at least right now. There's no
That's
point.
that's fantastic. We've written like 4 or 5 books on return on investment of HIT or of digital products. And we would get companies that would come to us and say, "Can you do an analysis and give us an independent third party?" And we've actually had to tell companies that have engaged us to measure the ROI. Nobody's using it, or they don't think there's any benefit. And so it's kind of great that you guys are at least being honest with those potential customers that you're not ready for us, or it's not the right time. So that's as helpful to them as actually deploying the product, I think.
For sure. And I'll tell you, like, I was talking to an entrepreneur the other day, someone who's earlier on in their career, and they were asking me, "Well, Josh, how do you know how do you know that the market actually wants the product? Like, what's the best way to find out?" And I said, "Well, the market votes with its wallet." And so this is exactly why I don't advocate for, free pilots in healthcare. Like, maybe if you're getting your very first user, you might do it for free, but pretty early on you want to start actually charging for your product, because unless people are willing to pay for it with, real operational dollars, you don't really know how valuable your solution is or how important the problem is. And
Mm-hmm.
I'll take it one step further. I often tell people, if I could pick between a hospital paying us, let's say, $10,000 for your innovation out of a hospital budget versus, let's say, $100,000 from a research grant. At first glance, an entrepreneur might say, "Oh, I'll take the 100 grand. It's 10 times more." But actually, if I'm them, I would take the 10 grand from the hospital budget, because that's real skin in the game.
Yes.
Because when it's real dollars from a budget, that if you waste it, the hospital will never give you money again as a hospital administrator. You take the initiative seriously. If you got 100 grand from a research, foundation that could care less of what happens at the end, they just won't feel like there's enough skin in the game to care. And you want skin in the game. You want people who are committed to say, hey, I'm ponying up something that means something to me, and I'm going to take this initiative seriously. And I think often entrepreneurs doing it for the first time don't understand the importance of that emotional investment. But as someone who's had successful and unsuccessful pilots and deployments funded by all kinds of different ways, that's what I found it worked best. They have to have real skin in the game.
Well, and if they've got that skin in the game and then you do deliver that 10 times value, they will tell others. And I've always said the secret sauce to selling in this industry is finding that first lemming that's willing to jump because they believe in you, and the others will follow. And that's kind of they jump off the mountain, buy into your approach and your product, and then they'll tell others if they've gotten that 10 times value. And the next thing you know, you're getting traction, you're growing, and you're expanding because of that value message. I think that's critical. So one of the things that you mentioned a little bit earlier is doing a pilot. And I think that's kind of standard in the industry. Let's do a pilot. And I've had some companies kind of push back at even doing any kind of proof of concept or demonstration. You mentioned don't do a free pilot, but what is your view on pilots in general? And then talk a little bit about the challenge we have with pilot-itis in this industry and how people do the pilot and then never scale it beyond the original project.
So I really don't like the word pilot, but I accept that some health systems still believe in the term. So I accept it. I'll use it. But my viewpoint is, if you're going to do a pilot, you should do so, and you should plan as if it's going to scale, knowing that some will fail, and that's fine. But you should plan as if the pilot will scale. And so what does that mean? So I think number one, don't do a really tiny pilot, meaning in my mind, don't pilot something with one doctor or 30 or 40 patients, because often you're putting the same effort to implement the innovation, whether it's for 1,000 patients or 30 patients. So if you're going to solve a problem that's important enough, you should be able to get more than one doctor on board. If you can't get more than one on board, you're probably not solving something important enough. Like, that's kind of a signal.
Well, I have had companies come to me and they're all excited. We got a client, we're working with XYZ health system. And then you find out they're working with one doctor who's kind of buried in the detail or the basement somewhere, and he's not really representing the whole health system. He's made an independent choice. That's not really a full-blown client. So I like your view that it's got to be big enough. And I think you've said somewhere else that I've seen that, and it's got to be strategically important to the health system. It can't just be this little fly-by-night thing. They've got to believe and want it to succeed.
It's true. And I'll tell you, like, so one of the myths with the example that you shared is that you'll meet, let's say, an individual physician, and they'll tell you, hey, if you just prove this with me, trust me, everyone else in my department will see the value and they'll jump on board, and the whole health system will jump on board. And I don't believe that they're lying. I know they generally believe that. But what I've found is that it's often not the case. And part of the challenge is sometimes that one physician is wrong about what everyone else cares about. They just often don't care about that problem or have a different perspective on what KPIs actually matter. And so you end up actually improving the metrics no one else cares about. But the other challenge I've found is that if you don't involve those executive sponsors from day one, they have no emotional attachment to your innovation. So you could actually deliver results, prove an ROI, and that executive team is actually upset because they never got to weigh in on choosing the innovation, on choosing the partner, and they feel miffed.
Mm-hmm.
And I've seen cases where the leadership team will just pick another vendor because they actually had a chance to choose them, even though your innovation actually worked in that one small setting. And so my feeling now is, you're right, you gotta align with a bigger priority initiative. You got to involve key sponsors, key executives from day one, and then map out what that roadmap looks like if it's successful. And so so phase one might be, hey, we're only doing this for joint replacement patients, and then phase two is all of orthopedics, and then phase three is a few more service lines, and then phase four is the whole enterprise. And there's no guarantee you'll get there. You have to earn each phase.
Right.
But if you plan it out that way, then you start to actually design phase one and phase two with the rest of the phases in mind, and you're going to actually not make the mistake of planning something too small, or planning it with the wrong people involved and all that.
Right. And I do agree with you taking that phased approach, but communicating it. This is the life of the initiative. This is how we're going to scale it from day one, can make or break it. It's part of that selling that change story, not just deploying the product, for sure. So there is back to the kind of the ROI conversation. You did a webinar with Dr. Ann Capillari from SSM, and in it you had a conversation about ROI to a physician is probably different from an administrator or a financial officer. And tell me a little bit more, because we believe there are multiple ROI stories and multiple value stories within each health system. How many do you plan for? I mean, how many stakeholders do you have to deliver a different message to? Physicians, finance, et cetera. And how are those stories different?
One of the toughest things about building a digital health company and a solution where, like in our case, we have patient users, right, and on one side of the table, but they're not the ones paying for it. And the ones paying for it for us, who are typically hospital administrators or executives, are not at all the users of the actual tool. And so there's that big disconnect between use and who's paying for it. And so for companies like ours, we found that there's kind of three buckets of stakeholders we have to prove an ROI for. And you're right, the ROI is different and the value props are very different. So for the patients, we found that the ROI for them is, how has this improved my experience? Does it help reduce anxiety about my patient journey, or improve confidence, or make me feel more empowered? And so the product has to work for them and deliver that value. And then for the clinicians and the medical staff, for them, it's about, okay, does this actually improve my patient's outcome? Does it save me time because I'm spending less time, handling phone calls, or spending less time on repeating education? And then for the executives, it's, yes, we care about outcomes, but we have to see lower costs of care, or increase, net profit per patient. And so the financials really matter for them. And so you have to be aware of and speak to all three. And that's also the hard part about digital health. It's not just, one stakeholder or one value prop. For us, it's three value props for three stakeholders. And I'm simplifying it, of course, right? As
Right.
You get really granular. We have to explain to the office assistant why it's worth their time to educate a patient, for example.
Yeah, I had one CEO tell me that he worked really, really hard to sell something to physicians, got them all bought in, they were ready to go. And then the people who were the barriers to change were the office managers. They didn't want to have to deal with it. And it was kind of a behind the scenes, passive aggressive resistance. And he said, it took me a while, or us a while, to realize that just because you've sold the docs on one thing in from a perspective they care about, you have to think who else can run you off the road, so to speak. So,
Well, I'll give
well,
you a quick story, Pam,
yeah,
on that. So,
yeah,
years ago, one of our biggest mistakes was we had sold our product to a hospital, top down through leadership, never had to involve physicians. And we thought, great, that really shortened the sales cycle, right? And you know what happened? We implemented it, and the physicians revolted. They were upset they were never consulted, and the implementation failed. And, I'm sure if we had made them part of the sales process and educated them and gotten their feedback, they would have loved the product. But we had burned that bridge because we skipped a step. And so now we tell health systems, hey, I don't care if the CEO of the health system wants to buy this. If we don't spend the extra time needed to get clinical buy-in, it doesn't matter. It's going to fail. We're going to have both wasted our time and your money. I don't want to do that. So we'll extend the sales cycle. Let us meet the clinical teams and let us earn the right to play with them.
And you'll find a lot of skeptics in those clinical teams, and you have to go through the paces of engaging those skeptics, even if they are difficult to work with. And there are a lot of them that can really try to throw a wrench in the process just because they don't want to put the time in, or they've had an irritating day, or that's just their personality. So for sure. So does it help that you're a physician when you're talking to these guys, do you think? Do they
It
appreciate
does.
that?
It does. And I mean, and I don't think it's necessarily that they go, oh, like he has a clinical background, like we trust him more. It's more that sometimes there's just I'll be honest, like sometimes like my team is so good that like there might be a, let's say, a 1 hour meeting with the health system where my team's running the show. I'm just sitting there on the Zoom and I'm not saying anything, or I'm not really saying anything for the whole time, but there might be that one really weird question that just because I have that clinical experience, I can answer that question well enough that the other team goes, okay, I feel comfortable continuing this conversation. Because, in healthcare, it's just these little details can really throw people off. And just, sometimes that's all I'm needed for, just that one little thing. And so you're right, it does make a difference. And I'll give you another example of that. So in our team, actually, when we implement the solution, we have clinical people on our end that work with the clinicians on the health system side to do all the configuration of the protocols and the content. And so often we hear from health systems like, wow, like I was so glad that someone on your team was clinical because I could just speak the same language and they understood me. Whereas with other companies, I'm always talking to an IT person and I feel like they don't understand what I'm looking for. And so we designed our team to in some ways mimic the makeup of a health system team. And that's really made a big difference.
Well, and I've seen that for years. It's building that trust is essential. It's, do you speak the same language? Do you know kind of have you had some of the similar experiences? Do you know some of the same people? I mean, it's building that credibility. And I think that is where people new to this industry, or companies that have been successful in other industries and try to come into healthcare, that's where they struggle, because they don't talk the talk. They can't, they don't know the same people. They don't have the same track record. It really does make a difference. So I find it interesting. We've actually had clients that have been from Europe and Canada and are trying to come into the United States and sell what was successful in those two environments, but they've struggled because, we've got different regulations, got a different reimbursement system. How have you guys seen it, being based in Canada, but doing a lot of work in the States? I mean, did you have any surprises? What did you have to do differently? Tell me a little bit more about that.
It's so fascinating because the medicine and the patient care is the same, right? But
Mhm.
the difference in payment models and the difference in incentives leads to wildly different scenarios of how digital health is adopted and valued. So I'll give you an example, right? So how in the U.S. compared to Canada, health systems are run more like businesses. Like there's real motivation to, increase patient acquisition, increase revenue, which means you don't really have things like backlogs of wait lists the way we do. Whereas in
Right.
Canada, we're not run like businesses. Hospitals are given flat global budgets. They have no incentive to compete for patient market share. And so we actually have very long wait lists. And so what actually ended up happening for us was in the US, because there's more incentives to improve consumer experience and you have more value-based care incentives than Canada does. If we actually, let's say, lower length of stay in the US, that's real dollars in the American system. That's real ROI. And so we're actually able to tie like length of stay reduction to more value to health systems and get excitement and adoption that way. Whereas in Canada, Um, again, we can cut length of stay by a day or two. It doesn't really matter to them because they're given, the way they're paid, it doesn't make a difference. And so we actually in Canada didn't really get much adoption until the pandemic happened, and then the government started actually paying hospitals dollars to invest products like ours to help cut the backlog and increase throughput because it got really bad with the
Mm.
pandemic. And so I think there's no easy answer, but it's more about, frankly, just spending more and more time with your customers and understanding what the incentives are and trying to figure out how you can align your product with the drivers that matter. Um, and yeah, it's unfortunately not an easy thing. You just have to spend time. And yes, it is challenging because it's almost like we have to wear two different hats depending on, who's in the room. Which is why, if you're serving multiple countries, gosh, like hats off to you if you can do that. I
Well,
think managing
I
two is
mean,
hard enough.
we even see that here in the States. If you're dealing with an academic medical center versus a community health system versus a children's health system, the incentives are different. The problems are a little bit different. So it gets back to getting to know that customer well and designing a solution. It's not one size fits all by any stretch of the imagination. So, well, one of the things you've done that I just love is you share um, your lessons learned. You share what's worked, but you also share your surprises and what didn't work sometimes. And you've told some stories about some of the unglamorous parts of working in healthcare, selling to healthcare, and I'd love it if you'd share with our listeners a couple of those stories because it never I always say I'm going to write a book one day on all the you can't believe it stories of what's happened in this industry. But what are some of the things to you that either really surprised you or you didn't expect, or maybe just kind of took the shine off of being in this industry a little bit?
Yeah, well, I'll tell you one story that touches on something we talked a bit earlier about. So I remember, and this happened to me twice at two different organizations, and this is a Canadian thing. This wouldn't happen as much in the U.S., but we would meet a fantastic physician champion who wanted to, pilot our product, and they would tell us, hey, if we just cut readmissions in half or cut ED visits in half, trust me, the hospital will pay for this afterwards. And so it sounded rational to me. And so we would spend 6 to 12 months implementing and piloting our product, and we'd cut readmissions in half, and we would take those results. We'd get a chance to actually sit down with the hospital CEO and present the results. And the CEO, and this happened in two different hospitals. The CEO would say, "Wow, these are amazing results, but based on the way the Canadian, government pays us, we're actually not saving money here, and so we're not incentivized to buy products like these because if we save money on these, readmissions or whatnot, the government thinks we need less money in the global budget next year. So there's no incentive, unfortunately, to buy this." And that blew my mind because everyone keeps talking about, oh, just reduce readmissions and there's value there. And it's like, well, wait, no. It turns out depending on the payment model and the incentive structure and all these things, that may not be true. And so what that taught me was actually we have to meet all the stakeholders. We have to meet not just the clinical, but the administrative ones and ask them, well, what KPIs do you care about?
Right.
Like what matters this year? Because that CEO would have told me on day one, actually, Josh, I don't care if you cut readmissions in half. It doesn't change anything for me. And I would never have expected that. And so I've learned you got to trust, but you got to verify for like multiple sources in the health system.
Right, right. Yeah. And have any of those that's a great lesson, but have there been any others that really gave you and your company a big aha in terms of this is how we're going to move forward and we're going to bring this into every client relationship, any of those unglamorous aspects of the industry that maybe really impacted the way you run the company on a go forward basis?
Well, I think one of the other things is just realizing we actually have to invest in multiple relationships across the board. Another sad story for us, but we had another partner where um, we had actually um, demonstrated major reductions in length of stay, and we were right that that was a good metric for the organization. But we actually got pushed out of the health system because it turned out that someone on the C-suite had a relationship with another vendor, and we had not yet built a relationship with the C-suite, and we just got kicked out. And and we hadn't earned the trust, and we hadn't earned the relationship of the folks who were ultimately writing the check. And so I think we've realized that despite all the value that we provide, if we're not helping our champions communicate that value internally, and frankly, if we're not directly ourselves having that relationship so we can communicate and get feedback, we're always going to be at risk in the relationship. And so
Sure.
now, early on, it's okay. It's great that people like the product. It's great that's creating value. But if stakeholders change, if people leave, we have to go visit. We have to go meet. We have to keep re-earning the relationship every year, day in day out.
Yeah.
Um, it's a people business at the end of the day.
I mean, it's very different from tech where software as a service, and you literally, somebody just goes and clicks and picks what level of member they want to be of or subscription they want, and there's very little interaction beyond that. So I think that's very, very helpful. So one of the things I always ask my guests kind of at the conclusion of our conversation is there one thing that we haven't talked about today that you think would be helpful for our audience as they consider the change or innovation they're trying to bring to the healthcare industry?
Yeah, I mean, my thing would be, and this is for anyone working on innovation out there in healthcare, just remember that what we do is very, very hard. It's true. But don't forget that, gosh, we have the best job on the planet. I mean, we get to work on really important problems. We get to help patients. And at least for me, there's nothing more rewarding than that. And it really does make all the pain and sacrifice worth it. And yes, it is often very painful being in healthcare, but I wouldn't trade it for anything in the world. The opportunity to impact the lives of so many, people, it's unbelievable.
Well, I don't know if you've heard of a gentleman named Quint Studer, but he's the guy that um, got people to start washing their hands in the
Mm.
industry, which is like amazing that it took somebody having a whole program and writing books on that. But he has written a book about once healthcare gets in your DNA, you can't. It's very difficult to work anywhere else. You can see that you've got that passion, you've got that energy and that excitement about it. It's hard, but you're making a difference. So that's very, very important. So thanks so
Absolutely.
much. I've really enjoyed our time together today, and I hope you have too.
Thank you, Pam. It's been wonderful to be part of this.